Okay, so thank you very much to everyone who's joined us for teaching today. So the topic today is palliative care in ICU, and it's been delivered by Dr. Rosie Bronner, who's one of the consultants in palliative care medicine, along with it looks like one of her colleagues, Dr. Coxon. So thank you very much for doing the session for us, and it should be really interesting, something a bit different as well. So yeah, really looking forward to it. We are recording it. I hope you don't mind.
That's absolutely fine. James, do you want to say hello? So we're in different offices because James is at LRI and I'm at Glenfield. But we're going to talk in parts because of our different experiences. So James, do you want to say hi?
Yeah, hi. I'm also with Sarah, but she's only popping in. One of the other consultants.
So we are going to talk a bit about what the specialist palliative care service is across LLR, just to make sure that you all know what sort of services we do and can offer. And we're going to go through a bit of our experience of input with you, what we think works well, where there's some areas for learning, and James is going to then sort of hopefully lead some sort of discussion about working together and how things may go. So as a specialist palliative care team, we work truly in the integrated care system. So we have consultants and nurses that work in the community, the hospital and the hospice. Within UHL, we're predominantly a CNS and medical team. Some of the other teams outside of UHL have other AHPs and different professionals who work with them. So for instance, we don't have a social worker that works with our team. We don't have dedicated physiotherapists or occupational therapists, but that does exist in other parts of the service across LLR. And we don't have specific psychology or counselling services within UHL, but the hospice does have that for patients that they see. So within UHL, we are a relatively small team for the number of beds that the hospital has. We've recently grown slightly and are now at about 3.2 whole-time equivalent consultants for the 3 sites, with more input at Glenfield and LRI than we have at Leicester General, where James covers there 1 day a week. We have a CNS team that rotate through the different hospitals and based at one site at a particular time, although we do move the CNS team or medical team members between the sites depending on the needs of patients, the complexity and the numbers at each site. And we also have 2 nurses who work predominantly on the emergency floor at LRI delivering palliative care there. So we take referrals from anywhere within the hospital for people who have a life-limiting illness. So that can be a chronic progressive illness, or it can be people who have been previously well and have a sudden catastrophic event. We see them when the needs are considered to be above the needs that the ward can manage on their own. So that is slightly different in different environments. And we'll come on to that in a bit. The referral needs to come to us via the ICE system at the moment, because that's the only way that we have oversight of the different patients on the caseload in the different services. But there is a mobile number which can be used to get urgent advice at a particular site. Some ward areas are very good at using that as a flagging mechanism for urgent things. I don't think we've had it used by you. There are base office ward numbers, but obviously if we're out and about on the ward areas, we won't pick that up until we're back. The CNS team work a Monday to Saturday face-to-face service from 9 till 5 p.m. And outside of those hours, there's consultant advice through switchboard. Now, again, we do know that you do utilise that. I've certainly had calls from your team at the weekend, less so overnight. That predominantly comes from ED, but we are available should there need to be specific advice. So we know that palliative care and the care of people who are dying is an important part of what you do, and I know that you place a lot of value on that part of your role, and we see that you do much of that extremely well. The things that we may be able to input into are some additional input into symptoms, some planning for onward care when people are going to a ward or potentially other places, and also some of the ethical challenges that you come across that we may have experience with either in that setting or on the ward environments. And we do get referrals from your teams for support to the team. It's usually alongside there being an ethical challenge or some other emotive issue there, but it can be helpful to team members, that the MDT, to have us as a slightly separate perspective to help look at things. I think when we've talked about what we see with you on intensive care at the moment, the predominant people that we tend to get involved with are people who have had an out of hospital cardiac arrest and have then been subsequently diagnosed with the severe hypoxic encephalopathy. Some people who come your way and then have a new diagnosis of extensive metastatic cancer, or some people who have a sudden catastrophic event where the recovery is poorer than anticipated. Most commonly, it's for things like symptoms, particularly when we're looking at transfers of care beyond ITU. People with prolonged admissions, so I think at Glenfield, the ECMO team pre-COVID used to invite us regularly to MDTs for any of the long stay at ECMO patients who were not showing significant signs of improvement as a trigger that there may be some additional support needed. We come to MDT discussions, and I think we come a bit more to patients that are awake than those that have sedation or are unconscious. So we wanted to get you to think a little bit here, and if anyone has any idea about things that relate to people who are dying, the language, the things that you do extremely well. We didn't know whether anyone ever tells you that, and if you know what you do that's good, and also whether there's any phrases that you are aware of that have maybe crept into your practice as a department that might be things to think about. We've certainly found in our palliative care team there's things that have crept into the way we talk about things that when we've reviewed it at M&M or discussed it amongst the team might not be considered to mean the same things by other teams as we mean, and we just wondered if you had any ideas about that. I know it's hard to be chatty on Teams, but does anyone want to volunteer anything?
I think we're probably normally try to be quite clear with and be fairly definitive with when we think patients are dying. Try to be very clear that that's the case and not try and sort of mince around the wrong thing, isn't it? But sort of skirt around the topic. We tend to be try and be quite direct about it, and always be fairly. We're probably quite bleak from the beginning because things are probably then can only get better.
Yep.
Hi, can you hear me?
Yep.
Hi, it's Rahul. So I'm one of the respiratory trainees on ITU, and I just wanted to agree with what Rosie was saying, that actually seeing it from a medic's point of view, I think you guys are really good at being very clear about prognosis and communicating quite regularly with family members. And I think the MDT works quite well in ICU, and everybody's sharing opinions about prognosis and then communicating that quite well to the family. So I think from what I've experienced, that's done really well here. And there's a lot of talk about, prognosis and when to continue with certain aspects of care. I think respect form's done really well here, better than actually in medicine, I've noticed. An escalation plan is put in place. So it's just a comment from somebody that's here on placement. So I think it's done really well, actually.
Thank you.
One of the points I wanted to make was that actually a lot of our patients are sedated, intubated, and ventilated, so we don't actually have to tell them directly. We're often dealing with family members, so that makes, It's not very often we have to tell the patient themselves that, you know, they're dying or there's nothing we can do, etc. It's usually through family conversations that we have to do it.
Yep, and I think that's my experience as well, and I suppose that's why I put the awake patients in a specific group. I think that there are some of the CPAP patients, some other patients, some of the ECMO patients who are awake, and I think they present a slightly different challenge to you, perhaps because you are so accustomed to the communication that you do very well with the families, that using that with the patient themselves, particularly as they often have, even if they're awake, they quite often have some delirium, or they're obviously very sick as well. Did someone else want to come in?
I just had two comments for the things about things to consider. I think one thing that kept creeping up, particularly during COVID, where we were having to communicate with families over the phone, is using words like stable. That has a very different meaning to relative sometimes than what we mean, whereas we mean stable as not getting better. They take stable as in, oh, well, that's a positive. And we did get caught out a few times, particularly with communication teams using that kind of language and phraseology with the relatives, because it meant something very different, whereas we just meant it's not getting better. Yeah, I think that was something that sort of flagged up quite a number of times with us. But something else, but my mind's gone blank. It'll come back to me.
And that's great. That's one of the ones that's on my list. So it's really good to hear that you've clocked it already. Anyone else?
I'll remember the other thing. Certainly from an ECMO point of view and having awake patients, we put a lot of emphasis on the fact that patients might need to do rehab in order to get better, or that's their chance of getting better. And actually, we might push that more than the patient necessarily has any interest in doing, and they might have a completely different outlook on where they are and what they want moving forward, and whether they actually still want to get better or not. And I think probably we sometimes focus a bit more on actually what we want in order to get them out of hospital, get into the next bit of their recovery, and actually that might not be what they're thinking about.
Yeah. So in what I've got, it covers that quite well. I think one of the things I've noticed when listening to conversations that you have with families in particular is that you're very good at mirroring their language, and those are things that we're taught in communication skills. You are very clear and use the words death and dying and those sorts of things, but equally when the families repeatedly choose to use another word, you will adapt to using those words, and so I think your communication is very nuanced and very good. Your documentation as a specialty is really clear, as Rahul said. It's really helpful when you've had a review on the ward and we end up seeing a patient because they're not suitable for intensive care. It's much clearer often what it is that you've discussed and what your rationale for doing things is. Some people in particular are really good at writing that in a way that helps everybody know what is happening and what has been said. In terms of things that don't always work from our side of the fence, particularly thinking about things from the ward when people are either on the ward or have come from ITU and are now back on a ward. So that stable thing that you talked about, but we've also seen quite a lot about they're not critical. So particularly in COVID, we saw that being used when they weren't considered to yet be ready to go to intensive care. They're not critical yet, they're not critical now, and some of these people were on 75% CPAP with not much or any wriggle room, and I think it was challenging when that conversation had happened in that way. Family members didn't always well understand how really very seriously ill the person was at that time. So you probably already know about that, but just to that was one of our observations. And then I think we're thinking here with the next two phrases that I've put up about particularly people who've had an out of hospital cardiac arrest is our experience with these ones. So or people who you're extubating and expecting to die fairly soon, particularly with the out of hospital cardiac arrests. It can be really tricky, can't it, to call whether they're going to die very soon after that or whether in fact they're not. So I know when we've been on call and when we've not, and we've seen people with you on the unit and then subsequently on the ward, that's one of the things we've reflected with some clinicians on the phone calls, but also subsequently family members. When there's the expectation that they're going to die very soon. Now, it may, of course, be that it has been presented as that's the most likely outcome, but there's a small chance that people will not die as quickly as that, and then we'll need to make a different plan. But some people find that incredibly challenging. And alongside that, it relates to food and feeding and hydration plans. People often feel relieved that you've said that they won't starve to death. But if somebody doesn't die soon after being extubated and they haven't got any form of nutrition or hydration and they don't feel that there was an active discussion about that, then that issue can start to become more tricky. Any reflections, James or Sarah, or anybody else on that?
I think one of the challenges we find is that everyone falls into these traps as well. You know, I'm a big advocate about using the word death and dying, but then I sometimes find that I still fail at that. So I think just, you know, it is about self-reflection about these different things. And leading on from that, sort of from the concerns about stepping down in nutrition, I think we'll talk about it a bit more, is that it is surprising how there are some patients which you can't predict who live a lot longer than people expect. And I think that's something to be aware of as well, because you then get the unusual sort of distress, the opposite distress, if that makes sense, of people saying, well, you said they're going to die and they haven't. And weird, you know, that feels really strange as a concept, but it truly is, where actually the familial distress is based on someone not dying rather than someone dying or deteriorating, which is a unusual one, but it's one to be aware of. There's a hand up.
Hello. I wanted to make a point about that conversation about patients dying, and I think the two, like it was mentioned, the two populations that kind of often refers to out of hospital cardiac arrest patients, who we see a lot of in Glenfield, and the ECMO patients as well. And that can be quite well enmeshed with a scenario where you are trying to kind of negotiate. I don't want to use the word negotiate, but you're pretty much trying to come to terms with the family on the fact that you know, all the interventions required to get this patient better have been employed, and we're in an intractable situation where the patient is probably going to die. And sort of strategies that I've used in the past is one to use terms such as, you know, we are not able to change the course of action here, and we're just going to let nature take its course. And nature taking its course in a disease process where we have no therapeutic intervention translates into a patient dying. But then I find that makes it easier to add to that narrative that they might not die today, tomorrow, or next week. It's just that we are not intervening anymore because any intervention at this point has no benefit, hence it's not appropriate. And all we're just doing is just facilitating a natural process, but ensuring that in that the patient is not suffering, they were hydrated as possible, and they're not in distress. And I found it over the years that's kind of an easier way to negotiate that, because And part of nature taking its course is that sometimes the end point is that the patient doesn't die, and they're in a state that they might be alive, but they might not die as expected. So we did have one case in our unit in which a patient was on this unit for up to 6 months, and pretty much that was the approach we took, where nature was just taking its course, and this patient was didn't pass away until almost for months, but it was quite moribund in bed. Yes, I just thought to kind of add that.
And another hand?
Yes, I think I'm chipping into a conversation about using words. On my recent on-call, there was a patient who's, I mean, it was, you know, family was present with the patient, and you know, he was on the palliative care installed, and I was actually called in the middle of the night because the wife who was present with the patient became very distressed because she was told in the evening that the patient has got hours, and the hours passed, and their beloved one still hasn't passed away. And I think that triggered quite in-depth conversation about things and repeating. And I think that I'm pretty sure I was in the situation in the past when I told a relative that probably they've got hours or days, use that sort of like a numeric almost theme and lead towards that discussion. However, I think they're using the right words and not promising relative anything, because as we heard, you know, it can take very, very long time. Yeah.
And I think the real challenge with this sort of thing is that there isn't a right or a wrong, because sometimes it will be right. When you really do think they're going to die very, very soon, and that's overwhelmingly the most likely thing to happen, and the family, for instance, are talking, or the patient in cases that we see are talking about what they'll do in a month or two, then sometimes there does need to be some form of numeracy that helps bring them further towards where you think what's most likely to happen. But it's mostly being aware about how many different things can carry different meanings to people, and just in some of the words that you've talked about as a group, particularly words like no benefit, futility, they are emotionally laden words as well, because they are our individual perception sometimes about benefit and futility, and people will have very disparate views about what benefits are, and that's what the law itself says, doesn't it? In the Aintree and James case, is about how you have to weigh up benefits depending on the patient and family context, as well as the perceived clinical and medical benefit of something. So I think that that poses a challenge, but also helps us to think when we're communicating in these really difficult situations, to kind of get to the nub of what is important and intrinsically valued by the patient and family, because it can help in some of those tricky cases, not always, but sometimes. So we're just going to move on to talking about some symptom things and how you might plan, and then James is going to talk a bit from then. So I suppose I have a special plea in this one. I think seizure management, when people go back to the ward, can be one of the things that poses for a palliative care team us with the biggest challenge from the management that you may be able to do in ITU versus what the wards are able to do. I've seen on a number of different occasions where they've been on several, sometimes 3 or 4 anticonvulsants, and then they've been stopped as part of you discontinuing treatment. And I think sometimes that relates to certain people's views that the person won't be experiencing distress from the seizure, and therefore it may not be indicated. But I think I would like to just just flag how really challenging it is to manage dying fitting patients on a medical ward. There's not many people around. They are at high risk of falling out of bed and dying fitting on the floor. And actually most people, staff and patients' families, find it distressing to witness somebody seizing as they die, unless they have a long history of seizures, and that's part of what is normal for them. So please do think about, if they're transitioning to a ward area, how you might be able to deliver their anticonvulsants. One of the other things we've picked up with you as a team a few times is just really thinking about what the nurses are doing in terms of giving boluses. I think your nurses are very skilled at picking up early signs of seizure activity. They, often can describe really in very significant detail what each person's seizures look like, whether it starts off as, that left-sided eyelid twitch was what I was told about somebody a few weeks ago. Other people, it's their arm or different things. Some people notice that they sweat first. Different things for different people, but I think your teams are often very skilled at knowing what they are and giving a bolus, and it not always being clear as we're transferring across how much of which boluses were for seizure activity, which are for sedation, those sorts of things. Helpful to think about what's running, what routes, how we might give it in the ward. For instance, if we think that they're dying and they're going to be really challenging to recannulate, are we looking at routes other than a cannula? That may, of course, depend on how much medicines they're having. So we can give lots of different things through a syringe driver. So Keppra can be replaced in a T34 subcut syringe driver, and we often use midazolam for seizures. So those would be our usual first and second line medicines, which probably works for the majority of people that we've seen. We've talked about phenobarb for some people with very, very difficult seizures, and we've also talked about running some of their other IV anti-epileptics alongside the Keppra and midazolam in people who've been needing particularly high doses. So those types of things, if they're on lots of different, 4 different medicines or really quirky ones, please do give us a call so that we can help work out what sort of thing might work on the ward environment. It's really difficult to get nurses to give IV midazolam on a ward, and obviously with the doctors not being on the base wards, a lot of the time have to come from elsewhere. Thinking about subcut routes for seizing as a first line option might be the right thing to do. And the other thing is about checking that the drugs are in stock, or the ward has had time to order them before they arrive on the ward. So any questions?
Is it worth mentioning, Rosie, that there's a single set of phenobarb that travels around the hospitals? So it depends where it is, but we sometimes find that it's in the other hospital, and you have to find where the travelling phenobarb is. Yeah.
There's 5 amps, I think. I think they were most recently at Glenfield, but who knows if you've stolen them back to the Royal now. So, but they're the sort of thing that we may have to get taxied across. So it's a fairly significant deal if we're nearly at the maximum of treatments. And absolutely, we're receptive to people having IV medications if that route is viable and continues to be an option. Any comments, questions? Otherwise, James will take over. Do you just want me to move the slides on, James, and then you?
Yes, I thought we could do this just like a COVID briefing, where I say next slide, please, and Chris Whitty style. Go for it. So I was going to just chat about planning onward care, and Rosie's already touched upon it a bit with slight symptom management there. It's just really about thinking about how do we, for the patients that are coming off an intensive care unit and I was going to use the word stepping down, but I don't think that's necessarily the right word. but moving to a different care environment, about how we can sort of preempt. And we suspect that this might be an area that we could work a bit more closely with you all as well, because we often will provide support on the wards themselves. So one of the things to think about is the symptoms themselves, and we've just touched upon seizure management as one of the options. The other option is, other symptoms might be pain related, and that's a good example. For example, is a PCA may be manageable in a sort of a higher dependency area, but on some of the wards that's quite alien to them. So there's one thing to think about. The other thing to think about is how lines are working, for example. So, your fancy 6-lumen central line is great for you guys, but unfortunately some of the wards really struggle with those sort of access points as well. So it's just about thinking about those in advance, and it's certainly something we can talk about and could help support thinking about for the more complicated cases. The other thing is about family. So with COVID, it's really shaken up the way things work, I think, from the point of view of family involvement, family visiting. And while the system is good in a sense that there is a degree of flexibility within the wards based on sort of decisions by the teams caring for the patient, they vary depending on where you are. And so it's something just to be aware of, is just to make people aware of the future visiting setups and the expectations of what they're going to, the contact and what's going on. I appreciate when in my conversations that I've had with some of your team members that actually some of these areas are really problematic, and actually decisions are sometimes made to provide continuity because of the real, because the feeling is that the expectations are just have been too high and the wards aren't able to provide that, and that's something again for us to be sort of thinking about, to be exploring and working through. And then the other section that's really helpful to think about is the sort of planning section at stage of it all. What is the escalation statuses? Could they potentially come back? This is a really good opportunity for this sort of to be laid out in the respect form, and as we've discussed before, actually respect forms are well completed by is quite well robustly done, and I think that's because actually ICU teams have a handle on all the different interventions, the escalation options. I suspect that some of the teams that don't regularly use them struggle with the concepts of what it truly means. So if you're on a medical ward as a medical doctor and you are discussing CPAP, if you haven't used CPAP for a couple of years, your recognition of what it is and how it works might be different. But if you're coming from a position where you're very experienced with it, then you might have more of a handle of it, and this so therefore provides a really good position to complete a respect form following discussions and from an MDT perhaps, or an involvement of family and the patient potentially. So that's one area that again I think is done well, and please carry on doing that. Something to think about is food and fluids, and this is a really challenging one for some patients coming from ICU to the wards for end-of-life care. This can be quite a contentious area. I appreciate that nutrition is sort of part of the, I don't know if is bundle the right word, but patients admitted to intensive care units, it's considered very early on within the care plans, and often is commenced early on in someone's admission there. The question is whether it's appropriate for the step, or for the sort of when they're moved from ICU to somewhere else. And it's this one thing to think about really, is how things are going to be. To me, and I think Ray's probably agree, one of the key parts is the recognition that we wouldn't stop someone eating and drinking if they wanted to. And I think that's an important way of sort of starting to manage some of the complicated ethics of these sort of decision making, this thing. Unfortunately, some of you may recall the Liverpool Care Pathways poor reputation was based on a misunderstanding about that you couldn't eat and drink at the end, and in the sort of end of life, which is not actually what it said, but it was interpreted that way, and so it's created a very sort of, it's added a complication to what was already a complicated thing. So it's worth maybe thinking about what is our plan here. Was the nutrition a acute intervention based on the fact that, you know, this person was going to improve and that's why we started it, but now that they're not going to have it, they're not going to improve, was it just part of that acute bundle of care that we were providing, and maybe could it be stopped as that's the most helpful thing for that person? There's a discussion to be had, and if in doubt, we should be asking for opinions, second opinions, maybe third opinions, and if it's really complicated, then it might require even legal consultation as well, which I appreciate people are very aware of and have been involved with before. And then perhaps one of the most important things is the timing of transfers. I think we've all been in situations where, due to numerous delays, the bed not being available, we then are faced with the problem of, do we transfer someone at 8 o'clock at night? And could we? And it's just something to be aware of. I think it's just about the fact that going from a a situation where there is 24-hour intensive involvement to a system on the base wards where doctors are based somewhere else and we're relying on those things, this is something to consider. Now, one of the great good things is that because you guys get up so early and you start your ward rounds so early, you're normally way ahead of the curve from those point of view, from that point of view. And actually, it's normally the wards accepting that at the slow point, the pinch point, and all of these things, but something to bear with. And I think there have been cases that we've been involved with where we've sort of said, could we just leave this till tomorrow morning, just because it would then allow us a fresh run at it rather than overnight trying to, compensate for that. Go for it, Rosie.
I think that partly just links back into that thing about drugs. I think one of the things we get really jittery about and late transfers is if we haven't checked that the wards have got the drugs that they might need, because if they then subsequently get to the ward at 8 or 9, which may be entirely unavoidable if there's that need for that bed, if they haven't had the sort of time to order the medicines, then pharmacy aren't on site and all of those things, and if they're CDs and if it's the only bit of phenobarb and you have to taxi it across from the Royal. So it's just about thinking ahead about those sorts of things as well, because we know we'd all like to transfer things in a nice tidy way, and it's not always possible to do it, but some things, handing over some things ahead of time can at least try to help make even the more difficult timings as good as they can be.
Would it be fair for me to say that some of these areas that I've covered are things that are challenging, or actually does it feel quite comfortable as a team when you are doing these sort of moves, these transfers, these plans? Is it? Are we recognizing the things that are challenging in these situations?
Yeah, I think so.
Yeah. Okay.
Most of what's challenging is actually that we don't work on the ward, so we don't know what's available and what isn't. That's
really fair. And I think, obviously it's vice versa as well. I suspect that the wards don't ask the right questions either, if that makes sense. So it's sort of a vice versa thing as well. And we need to remember also that with you guys who use paper charts for your, and the wards are electronic now. So I guess there is requires a bit of de-prescribing, probably from the point when they were on the wards before they came to intensive care, and then re-prescribing of the new medication sort of setup as well. I don't know if that's done in advance. Do you guys do that in advance, or do you ask the ward teams to do that part?
We do it.
You do it.
But yeah, it's more challenging, I suspect, from PRN side. It might come to us being electronic one day. You never know.
Mm-hmm. Okay, well, I'm definitely not here for that. I'm not here to to change your minds on that one. I've got bigger issues. Rosie, should we move on to the next slide? So if you leading on from that, actually, to be honest, here are some considerations to think about. Is making sure that if the patient is going to die soon and actually they might not get a review in time, if there is a risk of that, then medications for common symptoms at the end of life seems like a really sensible move. We've worked very hard, Rosie, Sarah and I, to make the new nerve centre prescribing easy for roughly what seems like the base, the starting place for what we would call anticipatory medications, or medications to be used at end of life. These are normally subcut medications, and they try and cover the sort of 4 major domains that we worry about. So that's pain, nausea and vomiting, agitation, and respiratory secretions, and breathlessness often falls into the pain category in that situation. So we try to advise that, but we very much recognise that if they've been on an ICU, they might have a certain profile of things already. So, you know, the starting stuff is probably not necessarily what they need to be on. We're very happy to be phoned to ask for advice about that, what we think might be the right move on that one. Conversion of IV to subcut, for example, is something to think about. I ran into in my head, we think over 24 hours for our medications because of our syringe driver thinking process. Well, I think you guys run on your, you know, milligrams an hour and things like that. So sometimes we have to sort of both think of the sort of what we're converting in between, you know, between the things to be aware of. But yeah, very happy to be phoned as well. And then touching upon here, pain and breathlessness. So palliative care, we have a lot of experience of managing these in dying, and also people with longer trajectories. That's a really fair thing. We do one of our bits that we don't touch upon in this conversation, but we do a lot of breathlessness management and people with COPD, who are out in the community living at home or long term with cancer. So we do sort of have good experience in these sort of these areas of management. And palliative care training requires hospice time as well, so we have, and community time, so we do have experience of these patients. So it's quite, we're potentially a resource that could be tapped into as well as when you're sort of planning the next step along for the patient that you're looking after. Rosie, should we go to the next slide? So that really leads me on to the next sort of section of this, which I don't know how long we've got, but really was just to open up to say that we're really keen to be helpful, and we do have interactions with you all. I was on the intensive care unit earlier this week in the Royal. I've been to all three recently in the last week or two. So we do get involved, and it's not just myself, obviously, it's Rosie and the other consultants as well in our team. We are keen to be helpful. We very much recognise that actually you guys do a load of what we would do maybe on the wards yourselves, and that's, we're not here to sort of step on toes and get too involved, but we are a resource, and we've been having a little think about how we can be more helpful. I think COVID has shown us about, well, not shown us, just shown lots of people about sort of how different models of working and actually the traditional setups have had to be broken down a little bit. So opening up to you all, is there anything that you think would be helpful for us to be more involved with? Anything that you think that there's a crossover potentially of sort of care? Anybody? If not, I've got a conversation starter, but no, shall I pop one in? I know you guys are having a discussion about stock lists at the moment as well on the system. Here's one to think about. When you are asked to review a patient on the ward, say an ED, CDU, somewhere along those lines, and they aren't appropriate for intensive care management due to, say, comorbidities or other concerns, how do people feel about that when they then write that in the notes? We've already touched on how important the documentation is and how good it is, but walking away from that, does that concern people? Do you worry about what their care is going to be like now, after that point? Is that something that people worry about? No?
I suspect the trainees and the consultants will have very different opinions on that.
Okay.
I think originally, when I first started working in intensive care, I did worry about it a lot, but I realised that as time goes on, there's nothing I can do to a certain level, because once they're beyond our care, it's sort of like, well, I could see this all the way through, but quite often what we see with intensive care and A&E and other ward interactions is that once we arrive, everyone departs. It's like, oh, ICU are here, it's all going to get sorted. So we could actually end up spending hours down there if we ended up sorting out everything. So we do have to try and make it clear to say that, okay, these are the reasons why we've made the decisions we have. We often have senior support. often call consultants for help and obviously document all of that and make a recommendation as to what can be done on the ward in terms of treatment options, and then talk about if the patient's for palliative care, then a referral might be appropriate, or to use certain drugs. But I do feel, as I said originally, I did worry a lot as a registrar when I made these plans to say that I put the plan in to say not for intensive care, and then walked away, and then ended up not being able to sleep at all if that happened to every patient we said no to.
Yeah, that makes a lot of sense. Hakeem, hands up.
Yeah, I thought to just share sort of, I think my experience is a bit unique, but it's quite similar to going to a ward and saying that a patient is not a candidate for ICU, and kind of for me as an ECMO consultant, we get referrals from around the country, and you have a discussion. Some patients are so young. Person referring is quite emotive about a patient, and you still go ahead and say, based on concrete reasons, say patient is not a candidate for ECMO. You know that kind of could translate, most likely translate to them dying. And so I think you've raised a really good point there, is how do we personally wrestle with that decision, knowing, just trying to separate sort of cause and effect, because as emotive beings and human beings as well, there's no doubt that sometimes you go home and think, I have not helped anybody today. I've just said no to a whole bunch of people and have all died. And I certainly feel that way sometimes. During the COVID pandemic, we're having upwards of 30 referrals a day. And for most of them, you'd say they're not candidates, and that it's quite likely that most going to die. That the palliative journey starts then. And I think one way I have kind of resolved this is two ways, because actually I think I've thought of keeping in touch with the other side, is that I have put a lot of patients of ECMO, taken up a lot of patients to ITU, and I've seen the results, and actually sometimes it's not nice. And I think is having a clear definition of what a treatment is. A treatment is only a treatment if it's beneficial. It can actually be harmful if there's no benefit. And when I rationally, reasonably, after consulting with multiple colleagues, which we do all the time, say no to a patient to either ICU or for ECMO or one form of escalation, I think the way I resolve it personally is that ultimately what we try to do every day for our patients, whether we give them an escalation of support or not, is do the best for them. And sometimes actually escalating support to ICU or for ECMO is not the best for them. And upon the realization that they're unlikely to survive, what is probably best for them is to give them a good death, and give them a nice peaceful death rather than. And I think that's how I resolve it at the end of the day. Rather than, because I do agree, we're all human beings. It can be tricky and can weigh on your mind sometimes.
And would you ever say, when you've said, when you've clearly laid out your concerns and explained your decision, would you ever say, I think you should contact your local palliative care team? Would that be something that would be part of your suggested plan?
We have done that, and I have personally done that a few times, where actually having a conversation with me has led to both senior clinicians, either referring and me, come to realization that actually this patient is dying. I think we should actively start off a palliative approach, and that stuff often starts off a process where they contact the local palliative care teams, especially in the really young patients where the emotive issues around palliation are too much for the team just to handle on their own.
Yeah, I hear that. It's interesting. I think one of the challenges that you as a team all have is the sort of concept of a parent team. So you're in consultation with another clinician to try and work out a way, whether you are going to take them on within your service or not. And it's interesting because I haven't got the data on it, but I suspect anecdotally we don't get that many referrals directly off the intensive care review. And it's something that we've discussed as a team before about, is there a place for that? Now, we're a really small team, so I think if we came with you to all your reviews, we might get destroyed. But it is interesting, you know, and I'm not kidding, we would get destroyed. But there feels like it would be nice for us to explore locally whether we should be saying permission-wise, actually, do you know what? If you've gone along and seen someone that's sick enough that needs your support but isn't appropriate, then arguably, almost by definition, they're sick enough to need our support. So I think there might be something there. It needs to be built up. And again, I don't want to give ourselves a lot of workload, but I suspect that there may be an opportunity for us to build something more there, which would actually also help you guys sleep at night a little bit more. You know, if you say, well, I walked away from that situation, we've not done, you know, we can't offer the services that they had hoped we can, but what I've left is actually a really robust setup, then actually that feels like that's really helpful. And I know you've got lots of hands up. One more point to add to this.
Can I just add to that, just that point you just raised there? Yeah. I have been in situations where I couldn't walk away with a palliative setup on the ward, and I've ended up taking the patient to ITU to palliate them. And that's partly because I felt more comfortable that I'll do a better job on the unit, because I wasn't too comfortable on the ward. So you're quite right about that. Yeah.
And I think that, and you know, and we are very open and honest to say that we can't, you know, we struggle to see all the patients that were referred, you know, so sadly there isn't our service is growing and becoming more robust, but it isn't perfect. I completely forgot the point I was going to add to that now. It's gone. Never mind. It'll come back to me in a second. It was really good though, everyone. Just be aware, it was really good. There are some more hands up. Did anybody else want to comment in on that?
Yeah, I just want to say from a trainee's perspective, generally the kind of way I kind of work would be that we will call down to either A&E or AMU or wherever to provide an opinion on whether organ support would be appropriate or not. So I think there's a bit of a fine line to sort of tread, because you do occasionally then get sucked into, well, if they're not going to be for ICU, who's going to have the discussion with the family about the respect form then, and all of that sort of stuff, which when you've got multiple referrals can be quite difficult to do. So I think, I don't know, I don't mind getting more involved with sort of getting palliative care more involved in the whole pathway, but I'd have thought that would kind of come from the parent team, because not everyone who's not for intensive care support means that they're not appropriate for other high levels of care on the ward. So then that kind of decision should really be driven by the referring clinicians and whoever's in charge of their care, I'd have thought. But ultimately for the trainees, we always have an out in that we can always write discussed with whatever consultant. So it helps you sort of, it sort of helps ease the guilt a little bit. But like I said, from our perspective, I sort of feel like you kind of put the impetus back on the referring team then, once we've said not for ventilation or filter or inotropes or anything.
And that just reminded me of something that I was going to say. I've got it back again now. Thank you. You've done well prompting me there, which is taking that point along, is if there are discussions, you know, if you have been drawn into a discussion with family or patients that has a place on the respect form, you know, that there, I don't think, to me, obviously you can discuss with the parent team as well, but there are some really, really good conversations that occur around respect, which don't then necessarily translate into the respect form itself. And obviously in a crisis, in an emergency, that's where people are looking. They're not rolling back through the notes necessarily that quick. So if a conversation does occur, which is respect form worthy, then and it's been discussed and agreed, then please, you know, I think it's really helpful to have that on there itself. I don't think it's very often, but there will be opportunities that, yeah. So if you've done all the hard work, just put it onto the respect form as well. Other people with hands up? Who's going to go first?
So James, can I just ask, following on from that, I didn't know what their consultant body thought about that. I think for me, that's been some of the things in COVID that have been really challenging, is when the ITU team have had some fantastic conversations. The med-reg has been busy in multiple arrests, and there's, for instance, you've discussed written in the notes that the patient doesn't want to be resuscitated, and the respect form hasn't been updated because that's considered to be the role of the parent team. Then sometimes the ward team don't feel able to give palliative medicines because they are still for CPR because somebody else hasn't come along. And I just wondered what the consultant, it is a really messy grey area, isn't it? And I just wondered if there was a team stance about that, or if it, just reflects workload and things at the time.
I think it's often individual. So, and also depends on the workload of the ICU team at the time. I certainly personally tend to try to start something on the ward. Like I said, in extreme situations where I think we have capacity on the unit, it's not once, twice, thrice of taking patients to the unit just to palliate them, because it was just the best thing to do. But that's not feasible all the time. And I think there's a bit of variability in the team. And I think, unfortunately, and there are times when patients fall through the gap where we've had a conversation, they're not for ICU, but the parent team have not had the bandwidth to kind of, initiate the palliative process, and patients are just falling through and had a really poor palliative experience. I'm sure that definitely happens.
And sometimes it is just the case of, if you've documented that DNA CPR discussion, sometimes, I remember a case on 35 where the nurses were outside the door waiting for it. Actually was Rahul, but Rahul and I signed a respect form. I looked at the obs at 8 in the morning, came on straight away, did that, and then we were able to make her comfortable. But it was the gap between anyone having the capacity to then come back and fill out the form, because from a nursing perspective, so it's not meant to be a criticism, it's just being aware that sometimes that specific thing that might not take lots and lots of time can create sometimes a gap. But I know it's a tricky issue we face as well in terms of parent team responsibility, our responsibility. Certainly I'm not saying that you need to go and have all of those conversations, because we certainly feel that we aren't the don't have the capacity and to go and do that on behalf of the teams as well.
I think a classic scenario where we see it, Hakeem, definitely at the Glenfield, is the out of hospital arrests who've got a cath lab. We've had long downtimes who, for the patient's best interests, intensive care wouldn't be the right thing to do. But just in terms of palliation and for the family, I think bringing them to the unit and facilitating that is definitely the right thing to do. We've had one that I was involved with last week or so ago, and moving the patient to the unit was the right thing to do for the family and everyone else involved, and the clinicians, to be honest with you, and the cardiology, who spent quite a long time doing a revascularization procedure, which ultimately wasn't going to be helpful, and for them to come to terms with that as well, I think was really important.
That's a very good point to make, and I think sometimes it is about exploring all the options, and I guess that's what that provides. You provide an environment for that sort of to work its way through. It probably is something that could be done in a non-ICU setting with the right skill set and the right. Does that make sense? Doesn't it? It probably could, but I think what we're really saying here is that sometimes those options aren't available. Certainly in the NHS, it doesn't feel like that sort of thing necessarily exists.
And death brokering is a phrase, isn't it? In sociology, they use that sort of process that you're talking about there as death brokering, and actually that can be really helpful for families. And that's where the sort of thing about witnessed CPR attempts in people that have had an unexpected arrest and things like that can be helpful, much less so usually in people who are dying, who then feel quite traumatized by seeing their very frail family member be resuscitated. But that death brokering and finding that right place is going to be different for all sorts of people in different ways.
I think I was just going to make a comment about parent teams and ITU reviews. I think what the pandemic has taught me, and probably lots of people, is that I think we need to work together. I think ultimately the parent team does take ultimate responsibility for the patient, but I think what I found during the pandemic is that sometimes it's appropriate just for the ITU doctor to make the decision about ITU. And I think it's up to the parent team to then sort of take that information and then have discussions with the patient about, well, you know, have got an opinion, and in light of this, you know, this should be the escalation plan from here on in. And sometimes actually the reason we've called intensive care is because it's the patients that want a second opinion, not us. So sometimes it's then appropriate for the ITU doctor to then lead the discussion in a more detailed conversation. But I think it does depend on which specialties you're interacting with. I think ITU and respiratory have a good relationship here. And I think, again, I can only speak for respiratory. Generally, we're quite proactive about escalation and, you know, discussions about resuscitation. And you might have different experiences, say, with A&E doctors or other specialties. But I do think it should be a joint decision. And sometimes having, you know, as registrars, you know, as a respiratory reg speaking to the ITU reg, sometimes, you know, the ITU will have a separate discussion before they go in and say, look, this is what I'm going to say. Do you want me to have the discussion about resuscitation, or do you want to have that? And I think you just need to talk. But I certainly do not think, as the parent team, should not be expecting the ITU team to come in and, you know, do it all. I think that's completely unreasonable. But there should be healthy communication between both teams. But yeah, that was just my opinion.
No, and it's a really valid opinion. We can't, yeah, as you're very clear, you can't take over everyone's care as much as you'd like to in some ways. And there are limitations of what can be and can't be done. And you're right, the responsibility does fall to the parent team in the end. I guess one of my things is that if a conversation's been had, then let's make sure it's, you know, if a conversation did go to DNAR and it was discussed, you know, then let's make sure that it is documented and available, because let's not waste these good conversations. So I think there is a role there. I think there is a role that if you're walking into a bit of a crisis and you think, you know what, this feels like palliative care would be the right thing here, then to strongly suggest the referral. I think if I had a referral from the ICU team who have been to review someone on behalf, because you were on the, you know, I wouldn't be upset with that either, if that makes sense, if you're highlighting a case. But obviously we fall into the same trap of not being able to do everything as well. Parent teams are tricky things, aren't they, really? You know, a good parent team is a great thing. Not such a good parent team is not such a good thing. So you're individualizing it makes a lot of sense as well. Oh, one more person, Paris.
Yeah, so just in keeping with the theme of parent teams, I think the parent teams who do some sort of intervention have a reluctance to let go of the patients, and therefore we get into a lot of difficulty. So cardiology was mentioned, but a lot of surgical specialties. And the other problem is difficult families. So I've certainly been landed in a few situations whereby it's quite clear that the patient is dying, though we're not able to have that conversation with the patient for whatever reason. The families are quite difficult in terms of, no, we must not palliate this, our loved ones. And so we get referred the patient for ITU, but not because the parent team genuinely thinks that they're a referral for ITU, but because they don't want to have that discussion. And then you get caught up into this world where you end up having this discussion with a family that you don't really know. And that already discussions have taken place whereby suggestions have been made for palliative care. In those situations, we'd actually just prefer it to be an honest and transparent discussion. So some parent specialists have done it really well and said, actually, we're having really difficulty with this family and getting them on board. And I think if ITU come and see this patient, and if you agree with our opinion, it'd make the family conversation a bit easier. And I think in those times, I don't actually mind going down to see the patient and having a fresh view, look at the patient. And then if we agree, great. But other times we get caught up in this situation where it's quite obvious that the family don't agree. The parent team don't want to tell us that the family don't agree, and they want to refer for that reason. And then we get caught up in this battle with the family, and it takes up a lot of our time.
Yeah, I can imagine that. And I think that sort of, sometimes it's a distraction, as in the parent team are asking you as a sort of almost like a, can we get someone else involved here because it's getting a bit heavy on our side, if that makes sense. I also suspect, reading the notes and reading in between the lines, sometimes that's used as a way of moving the responsibility to an alternative person, if that makes sense, which is, you know, it's hard for you guys to walk into. I mean, I really hear everything you guys are saying, and I think you really raise clearly a consistent message of the challenges that you all face when you see these really, really sick people. And that's the way I walk away from this, is thinking that, reminding myself about how sick the people that you see are. And there are ones that, you know, you're able to bring onto your unit and do really great things with. There are some that come onto great, you know, have all the great things, but it's just not enough in those situations. And there are some people that it isn't the right thing. And I think ECMO, for example, as an example, is such a sort of both a brilliant thing and also potentially such a curse, isn't it, as well? You know, you can do amazing things with it, but if it isn't right for that person, you're in a very sticky situation for that individual. My hope from sort of this, my prompting on this conversation, was to explore some of these sort of concerns that get raised, and just to be aware that we sometimes struggle as well with, you know, with conversations with teams where we might be invited along, but then nothing gets done that we get asked to get done. You know, that it's a challenge faced by all of you. So you're not on your own from these points of view. Different scenarios, but not the same sort of feelings and emotions about it all. I personally feel that there is a role for us to be working with you all. And yes, obviously there are some people it's not the right thing for, but for other people there might well be, you know, and I think that's something that I'm quite keen to sort of explore in the future. Maybe there might be some project work we can look at for some of these people as well. Journal club afterwards. Are we way over time by chance?
It's fine. It's really interesting. I'm sure nobody has an issue with talking for a bit longer on it.
So I guess, Rosie, do you want to go for it?
Go for it.
So one of our questions is something that the palliative care team have been involved with for a very long time, but obviously COVID has really made our lives very different, is in regards to that sort of ventilatory support, not intubation, but more CPAP, high flow oxygen. And how do we manage the people who are dying in those situations? And we have done a lot of work within the respiratory team and on ACB at the Royal, so trying to support these really quite challenging situations. And I'm going to tell you straight off that through the, you know, if I speak to my colleagues and ask them what are the hardest things that they face, apart from people being abusive and aggressive, I think they probably would say that difficult CPAP withdrawals on awake patients are just the worst things. I just realised we're recording, aren't we? I was about to use a word. They're really, really tough situations to be in, because you're trying to do the best by the person, the best by the family, the best by the team, but it doesn't always play out. And we have sort of worked with the respiratory team, the ACB team, but we are aware in the background that you guys do very similar things. And I didn't know whether this might be an opportunity for 10 minutes of sharing of thoughts about that, because we find it hard. So I suspect you guys find it hard, but that's an assumption. Please correct me if I'm wrong. Go for it. Whoever wants to go first.
So, who got first, me or Hakeem? I think that up until COVID, it probably wasn't something that we had to deal with very frequently, because I think the evidence for using prolonged non-invasive modes of ventilation for patients who would be for escalation to invasive ventilation was that it actually just worsened your outcome. So most of the time, we would only really get involved with those patients when they were intubated on the unit. And I think COVID's probably changed that, because we've now got a cohort of younger people who are having prolonged periods on CPAP on the unit that we wouldn't necessarily have had to look after before. I think we've seen it definitely on our unit with patients who've therefore been there for weeks, who we then think actually probably wouldn't gain any real mortality benefit from intubation, and trying to sort of have those conversations with people who are awake actually, and it is very, very challenging. And for me and Hakeem as well, we get referrals from an ECMO point of view for patients who've been on non-invasive ventilation for a long, long time, who then get intubated and fall in a heap, and then we'll have to try and sort of see whether we can help out and pick up the pieces from that side of things. And I think partly it's making the right decision before you get to that point. So not having lots of patients on CPAP who probably predictably weren't going to have any benefit from it, but you're doing it because you think you can do something rather than it necessarily being the right thing to do. I don't think that that's probably as true for the ones that we bring to intensive care, because purely by the nature of them, they would all be for escalation. But certainly I think there are people who we've come across on the ward who've ultimately been referred who ended up on CPAP who we probably would never have used CPAP on. And I think that's probably a challenge in terms of making the decision right at the beginning, so you don't end up in a difficult position at the end of it. But I think it's something that we probably don't have a huge amount of experience with, and we are trying to learn along the way. And it is very, very challenging. We have had a few patients on the unit that we have withdrawn on who were on CPAP, and that's just unheard for us, really.
Hakeem, do you want to go and then I'll come?
Yeah, I think, Matt, you're right. So I think you're very right about this. We've created a new problem, actually. We've created a cohort of patients who we'd never seen before. But there's an approach to it. And actually, like Matt said, we've been in this situation a few times, actually, on the unit. And I agree with you, they're incredibly very challenging. For me, CPAP and high flow has two purposes. It could be to treat and support underlying pathology, but also it can provide comfort in the palliative sense. You know, just taking away that sensation of air hunger and discomfort. And it's one of the indications to use high flow oxygen or CPAP in this context. But it's how you use it, I think. And I think for me personally, that's how I've kind of moved to the position of letting nature take its course. Been in this situation a few times, family see the physical removal of the CPAP of high flow nasal oxygen as giving up on the patient. And so this is my approach, and there's no evidence to this, but it involves communicating with the family and actually communicating on certain principles of what is support and what is palliation. And for me, if a patient is on high flow nasal oxygen, can be on high flow nasal oxygen 30-40 liters, but they'll have air. They'll have 21% oxygen through that because they're in palliative. Because what's giving them that support is a high flow nasal oxygen. Same thing with CPAP. I'll give them air through CPAP. There's 21% oxygen with a minimum, with no press support and minimal PEEP. Often in that context, it may prolong the journey, but my experience is that we've always come to the conclusion that we set out to in a comfortable way and without having any conflict with the family. Because the big point of conflict is often when you want to take off the support, and they see that as a no-no. They see that as you going against their wishes. There are some very difficult patients in which, like I said, we had a patient who was on the unit for 6 months. We actually got the legal team involved because the family felt taking the tube out, this extubating the patient, was giving up on the patient. So what we did was kept them on the ventilator, but on 21% oxygen. That's air and minimal support. But it took her 6 months to die, but she was in a persistent vegetative state, which has been my approach. I think it's a hybrid approach. I don't think it answers all the questions. I think a big factor in this is the family and the perception of the issue. What has made it worse, I think, for us, and actually for this new cohort of patients which we have on the ward, is that the family are often not there to see the clinical journey. Because often, I think in the past, when the family have been there to see how their loved one has deteriorated, they actually come to terms with it sooner, rather than when they've been at home, you've been trying to talk to them, they haven't seen the patient for days, and then all of a sudden they come and see your loved one, they are dying. It's often a shock. So I think that's my experience anyway. But I agree, it's a truly challenging scenario. And I think as time goes on, I think these patients aren't going away. We're going to have more of them. We'll probably learn ways of managing this a lot better. But I personally, I de-escalate support, but I leave the physical device there just for comfort.
So I think we have had experience. We had some experience of looking after CPAP removals in particularly in ILD patients who were on the respiratory HDUs, who do not behave exactly the same thing as the COVID patients, but perhaps behave most similarly to the COVID CPAP patients that we have. So I think as a palliative care team, we've been involved in really significant numbers of CPAP removals over the last 18 months. I think there's a couple of things that I wanted to say, that absolutely not everyone who's dying has to have their CPAP or their high flow nasal oxygen off. Sometimes they can be part of their palliative measures, that they don't stop people dying. So we see people who are very comfortable and obviously dying who remain on them whilst they die, and that's entirely not problematic, and for them can be the right thing. I think in people who are dying, we most commonly see that the high flow gives symptom control benefit and the CPAP less frequently. We've seen some really horrendous agitated CPAP dying on the respiratory wards and in ACB, where people are ripping at their masks, where it's no longer clinically effective, and it's been difficult, really difficult to manage. I think what we have found, and it's the sort of nationally been found, is that sort of medicines like morphine and midazolam, particularly if they're there in the background, can help. When you recognise that somebody's at the ceiling of treatment, they're probably deteriorating and they think they're going to die, they seem to enable the natural process to happen more cleanly than it being a stark sort of problem related to the CPAP. And actually there's evidence from sort of, I think it's the early 2000s, where they did a study looking at people who had benzos and morphine at the time of CPAP withdrawal, and actually, so particularly in things like MND at that time, that actually it giving those sort of medicines around the type of removal actually means that they die less, usually less distressingly, but also not as temporally associated with the removal of it. So we do lots of these sort of flip overs, either with morphine and midazolam or that in the background, and then sometimes additional bolus doses. So there is a guideline. ED have done one, and I wondered whether that might be worth putting our brains all together so that we could come up with something that worked in the different places, because I think there's different ways to do it, but that there's some things that we could consider that might be helpful to all of us. If anyone would be interested in doing that, then please get in touch. I'll pop the reference in the chat as well for that paper. And if any of you are into reading geeky books, then just lots of the way that you're reflecting about this sort of death brokering and experiences. There's a book by Stephen Timmermans called Southern Death and the Myth of CPR that talks very much about some of these things that you're talking about. So it's an interesting work read that's a bit old now, but very relevant still.
It feels like we've found a natural conclusion, not a conclusion, this never ends, but it feels like a point where we've exhausted you all with all our chat. I think the final thing from my side of things is that we're here to be helpful. If you think there's something, a role for us to play with particular individual cases, then please get in touch. And I hope that in the same way that we can demonstrate that we are useful to you all. I think there's definitely scope for us to build more of a relationship between all the teams. So take advantage of us, and even if it's just a phone call over, to ask a question about, something, drug conversions or whatever, then please, give us a shout about that stuff. And yeah, as I said, you'll probably see us around anyway a bit more as our team grows. Hopefully that will help. So yeah. Good. Rose, anything else you want to add before we sign off? Any final questions?
No, just to say thank you. It's been a really useful session.
Yeah.
I think palliative care is one thing that is often underappreciated. And I think in our specialty, it's actually, COVID has brought a lot of things to the fore. And I think this was really a timely presentation.
Yeah, thank you.
Thank you very much.
We'll call you from when we say no at the Royal, in A&E and in AMU all the time.
Oh, should we give you my personal number so you can just give me a shout? Yeah.
Yeah, that's fine.
The final thing to say for me is that I did ICU as a SHO, and that's when I decided to do palliative care, because I realised that that's all that a significant amount of the work was just palliative care. Didn't fancy doing intubations, but I fancied doing the palliative care side of it all. So that's just interesting that actually it was ICU that really solidified that for me.
And I think that, and I just would echo that, there really is a lot of commonality in what we do. And Kaz on the call, you know, there's at one point there was a really difficult encounter that I'd had pre-COVID, and actually she was the only person that got where I was coming from, and actually talking sort of peer to different specialty, but there is that sort of nub of some of the difficult stuff that we share. Thank you for your support during this time as well. I know you've had a fairly rubbish lot of time, and you know, we really appreciate what you do, and you do some really stunning conversations, and that's the bit that we see the most. Obviously you do all the other stuff, but the bit we see is that, you know, the really good conversations, and it really does make a difference to what happens on the wards. So
great.
Thank you, James. Thank you, Rosie. So I think that was concluded quite nicely there, and yeah, certainly we will be calling you guys for more help in the future. So moving on to Journal Club now, I think Ben Shuker is going to be presenting a paper. The paper is going to be the TOMAHAWK paper. I think, Ben, you're in LRI, so over to you whenever you're ready.
My name's Ben. I'm one of the registrars in intensive care and anaesthetics here at the LRI at the moment. I've been asked to do this journal club today looking at the TOMAHAWK trial. So this is a paper that was published in August this year in the New England Journal of Medicine. They managed to get this catchy title of TOMAHAWK out of angiography after out-of-hospital cardiac arrest without ST segment elevation. I'm not sure how they managed that. Why they've done this, so the trial's aim was to identify whether immediate angiography versus late angiography plus or minus PCI for adult patients over the age of 30 admitted after an out-of-hospital cardiac arrest without ST elevation improved 30-day mortality. And there's some other outcomes that we'll have a look at. A bit of background to this. So the 2021 European Resuscitation Council guidelines do suggest that you should consider emergency angiography for patients with a high likelihood of an occlusive coronary disease as the cause of their arrest. So typically this might be indicated by hemodynamic or electrical instability. The COAC trial looked into this a little bit and demonstrated no improvement with 90-day mortality with immediate angiography for out-of-hospital cardiac arrest where there wasn't any ST elevation. And there's another trial going on at the moment, which is the DISCO trial, and their pilot study showed that about 37% of these patients who did have an immediate angiography had a culprit lesion, which they defined as stenosis of greater than 50%. So this trial was a multi-center investigator-initiated randomized international open-label trial. Patients were immediately screened for inclusion on admission to ED and then were randomly assigned in a one-to-one ratio using a web-based system. The primary outcome, as I said already, was 30-day all-cause mortality, but they also had some pre-specified secondary outcomes and a pre-specified subgroup analysis. The primary analysis they performed on an intention to treat basis. The setting and population, they did this across 31 sites in Germany and Denmark between November 2016 and September 2019. There's quite an extensive list of exclusionary criteria, but broadly these are the main bits here. So included, as we said before, adults over the age of 30 who'd had a resuscitated out-of-hospital arrest, and they included both shockable and non-shockable rhythms for that. They excluded ST elevation or left bundle branch block, excluded if there's no ROSC, naturally. Severe hemodynamic or electrical instability were excluded, which is interesting if you think about what we just talked about from those resuscitation guidelines, where that's probably the group that you might think about doing an immediate angiography. Also excluded if there was an obvious non-cardiac cause, so it's neurogenic or whatever else. In-hospital arrests were excluded, pregnancy was excluded, and if for whatever reason a participant in a different trial that conflicted with this, then they were excluded. So they had 558 eligible patients. 4 of those failed to be randomized, so they weren't included in the analysis. They started with 281 in the immediate angiography group, and they were left with 265 that were analysed, and 273 in the delayed or selective angiography group, which we'll talk about in a minute. 265 of those were analysed. They were fairly similar baseline characteristics, but they did note that there were slightly higher rates of smoking, coronary artery disease, and a shockable initial rhythm in the delayed angiography group. In terms of intervention and control, so the intervention arm had immediate angiography, which they just described as transferring to cath lab as soon as possible. The control arm, again, so they talked about either a delayed or a selective angiography. So this is where there's a little bit of a bit of a grey area in this trial. So they'd be transferred to ICU for further evaluation, and then there's a lot of clinical judgment about whether or not they thought there might be an acute coronary trigger, and if that was the case, they could still go to angiography, but they tried to make sure that it was at least 24 hours after admission. However, if they had any substantial myocardial damage, which they defined as a troponin above 70 times the upper limit of normal, or a high CK post-arrest, or electrical instability, or cardiogenic shock, or a new ST elevation, then they'd say fine, take them to angiography before that 24 hours. And because it's an intention to treat analysis, these patients would have then been included in the kind of results. Other management, so in both arms, revascularization during angiography was attempted if there was at least one major coronary artery that had disease that was relevant, and they ideally wanted sort of percutaneous coronary intervention versus CABG, but that was at the discretion of the managing team, and otherwise just normal post-resuscitation care. So the primary outcome, this is all-cause 30-day mortality, and approached sort of statistical significance with a p of sort of 0.06, but essentially they're saying there's no difference between these groups. And then they've got a subgroup analysis, which can you guys see that okay? If not, I can give you the highlights.
We can see it.
Okay, fine. So as I said earlier on, part of the design of this trial is that they had planned a kind of subgroup analysis, and this is kind of just demonstrating that essentially whether you account for age or presence of diabetes, whether it's a shockable or non-shockable rhythm, if you had any more confirmation that it was a myocardial infarction as the trigger of the arrest, so gender differences, use of targeted temperature management, and kind of time from arrest to ROSC. None of those had any impact on whether you had a better outcome at 30 days in terms of mortality in either the immediate or delayed angiography groups. Secondary outcomes, they had a look at a fair few different things. I'll pick out a few that were more interesting on the next slide. But broadly speaking, not much difference in either group. The only one that was really significant that was of interest is that they looked at 30-day mortality from kind of severe, any cause or severe neurological deficit. So in the immediate angiography group, they had 64%. In the delayed and selective angiography group, this is 55%. In the text, the authors talked about this a little bit and obviously suggests that we interpret it with caution, but kind of acknowledge that if it's valid, then it could be that this immediate angiography group is leading to a delay in diagnosis of an alternative cause of arrest. And this kind of effect was also seen in if you just separate out death from that and just look at neurological deficit, which they defined as a cerebral performance category of 3 to 5. So this is kind of severe brain injury. Again, that was seen quite more significantly in the immediate angiography group. Other kind of typical outcomes that you might think about post-MI or arrest, so another MI or rehospitalization with CCF or AKI needing renal replacement therapy, no particular significant differences there. So the authors concluded, as you've seen with the data, that among the patients who were resuscitated without hospital arrest, without ST segment elevation, there's no particular benefit in terms of 30-day all-cause mortality from having immediate angiography. So a few strengths and limitations. A few of these from the paper, and I'll do a couple of sort of my interpretation of this. The intention to treat analysis, multi-center design with appropriate randomization strategy, that is a well-designed trial. The only problem really is that because of the nature of the trial design, it's going to be obvious which patients are in which arm, and the authors recognise that this might influence the decision making for this. Excluding ST elevation, hemodynamic and electrical instability, as well as in-hospital cardiac arrest, does limit the utility of the findings. And they also commented on the fact that they kind of lost 4% of their patients from the analysis because they're either excluded or from their criteria, or the patients have withdrawn their consent. And they'd aimed for a power of 80% with this to get a significant difference for their analysis, but they only met 79%. However, the results kind of support the previous findings of the COACT trial, but what this has added is that the COACT trial only recruited shock or that of hospital cardiac arrest. Immediate angiography in this demographic, another thing just to think about is that it's probably only likely to benefit those who do have a culpable lesion that's amenable to revascularization, which, as we talked about previously, is estimated around 40%. The other patients that do go through immediate angiography might not actually benefit from that and are just exposed to, you know, procedural risk and delay in alternative diagnoses. And what we were talking about earlier, teasing out this kind of increased number of neurological deficit afterwards might be related to that. The patients who were amenable to this early revascularization, there's probably going to be some longer term benefits if they survive, so possibly less likely to have a chronic heart failure outside of this 30-day window that's in the trial, and they might not be, you know, re-hospitalized with any other acute ischemic disease. Another thing that the authors noted is the primary cause of death in all of their patients from this trial was related to neurological injury, and that probably is still likely to be the major determinant of, you know, outcomes for out of hospital arrest. And, you know, even though we're looking at this kind of immediate or delayed angiography revascularization, neurological injury is probably still the major kind of cause of mortality. That's it really. I don't know if anyone's got any comments or if they've read the paper, anything else they wanted to ask about.
I was just going to say it probably doesn't help us getting patients over to Glenfield from out of hospital cardiac arrest in A&E as a general rule, but never mind.
Yeah, quite right. Someone else had their hand up, I think. Dr. Youssef, I think.
I think Sam had his hand up before me. But
oh, sorry, carry on. I can't see it very well. Please carry on.
I mean, so we've had conversations with our cardiologists, and just to reassure you, the plan is still to have that minor pathway where patients with out of hospital cardiac arrests still come to Glenfield, because as you said, the paper has stipulated that it's a delayed angiography. They still need specialist cardiology care, and I think this should still come here. I think we stand a lot to lose in the care we provide these patients if they go elsewhere. And the national pathways for patients with cardiac arrest is to go to a centre that clusters them, and I think at the moment we have that in Leicestershire and Rutland, and I think we should continue it. And that is the thinking of the cardiology team. What our cardiology team have latched on to is they don't want to, and this is, I'm saying this cynically because this is our group, but you know, it just reduces the frequency of how many times they have to wake up in the middle of the night to come and do a PCI for a patient. It just means that they come in and they are on ITU initially, and like you mentioned, the grey area is which patients are you going to, how do you decide which patients need then the delayed PCI? The one other minus of this study, and this is the criticism for this study, is that we know that ischemic heart disease outcomes data have more of a long-term impact than a short-term. This has just looked at 30-day mortality. If you look at the biggest cardiology studies, I mean, if we start off from the IABP SHOCK 2 trial to corporate lesion and to more of the more recent stent studies, well, because heart failure from ischemic heart disease is a malignant condition, it's burden as high as cancer, and what we don't know is how this new strategy might contribute to that population of patients who 1 year, 2 years down the line can't do the work they do on heart failure medication, having reduced exercise tolerance, and on the other sequelae. The difficulty there has been, it's been quite difficult to measure. And there's still a significant burden because we know that 30 to 40% of these patients will have a culprit lesion, and how that impacts on them subsequently is the issue. I guess the only way we would know if, because I think there is traction within the cardiology group to change their management this way, is if the heart failure burden down the line is either increased or decreased. And I think only time will tell. But it's a very interesting study, and it helps the cardiologists to plan the working life a lot better. But I think the onus will still be on cardiac ICUs such as ours in Glenfield to continue to receive these patients, manage them and try and optimize them. And certainly the very high risk ones, those who have cardiogenic shock, should still have immediate PCI, and that will be a discussion we'll be having with the cardiologists to try and press on that. And I think the work for the future is, how do you decide those patients who you should bring forward the need for PCI? What criteria? Because they've clearly said cardiogenic shock, but if they're not in cardiogenic shock, what other criteria are you going to use? Because there's a big spectrum between having a normal heart and being in crashing cardiogenic shock. There's a lot of things in between. NYHA class 3, class 2 patients who have a huge impact on their lives. They're not normal. They will go home, but they'll be on heart failure medication. They won't be able to be as active as they were before. Thank you.
I think Sam had his hand up. Sam.
Thanks, Ben, for presenting this. It's an interesting paper. I think possibly Hakeem summarized. I had a couple of fundamental issues with the paper itself. It's a good paper, but I think the question is the wrong thing to ask. So we know the mortality in the first 30 days is mainly driven by neurological insult. I think if you're going to study the outcome, you need to study the quality of life of primary versus delayed PCI. So out of the 50% of patients that survive, which kind reach what we expect here in Glenfield in a PCI primary center. So that's provision of tertiary cardiology input into the early journey of these patients will dictate the long-term outcome. And I think a 30-day mortality is completely the wrong thing. The second thing is that area, which I couldn't find actually into the details of the study because I read it before today, about how the decision was in the intention to treat group where people decided within 24 hours that some of the control group might go for primary PCI. So that in a way tells you this is, I don't know, I think if it wasn't a COVID time, this study wouldn't attracted that much attention. If it wasn't the massive queue of patients who need cath lab and PCIs and other things. Because whatever study you do, in my opinion, if I come with a cardiac reasons to have a cardiac arrest, I want to have my PCI half an hour earlier. And in Glenfield, in my experience in the last 5 years, there was only one delayed diagnosis of subarachnoid hemorrhage on a young lady, which went for primary PCI, which was the wrong thing. On a balance, I think it's the right thing we do. Between us, our registrars always decide to go PCI or CT. If they think clinically CT is more appropriate, we do the CT first. And that's usually a young female who had a sudden collapse from a normal consciousness level, not someone presenting with chest pain and collapsing, if that makes sense. So Hakeem already said we're still running through the pathway, and that's the national direction of NHSCI, because there's the plan in the next few years to have a PCI centers for intensive care where they accommodate these out of hospital shockable rhythm arrests. That's my comment. Thanks.
Thank you. I think even when you said about the intention to treat analysis, I did try and have a look and see if they included any numbers, but certainly when I read it, I couldn't spot anything. And I think it's a very good question. Anyone else got anything they wanted to say about it?
It's a vague part of the paper, and I don't know if you've had access to the appendix as well. But I've looked at the appendix, looked at the paper, and there's nothing to stipulate how that has been agreed. And to be honest, I wonder how some papers get published in the New England Journal of Medicine, but I'd expect a paper of that quality to actually stipulate that, but they haven't. And I think it is when me and Sam in the middle of the night are having a conversation with a cardiologist that I think they should come and do a PCR on a patient. Those are the kind of things we would probably be kind of trying to sort out, and I don't think there was going to be an objective way of assessing it. We would have to kind of just use nuanced clinical judgments to make that decision, really.
Sure. Thank you. I think that's, unless anyone else has got anything to say, that's me done, Paris. Thank you.
Fantastic. Thank you for an excellent paper presentation. Thank you for all the contributions.